Thank you, Dr. Anita, for the kind words of introduction, and Dr. Madhuri for the invitation to be here in this important workshop today being conducted in association with the Endocrine Society of India and the PCOS Society. So I'll speak. I mean, we had a very interesting session just now, and many of the aspects were discussed. So I'll be trying to cover in the next 15 minutes or so. I'll give an overview of all the mechanisms which cause the menstrual irregularities in women with PCOS. So let me share my screen. So the title given to me was, yeah, is my screen visible?
Yes.
Yeah, thank you. So the title given to me was, does PCOS cause oligoamenorrhea? So I'll try to cover that in the next 15 minutes or so. So basically, we have been discussing about PCOS, and we know that this is the prevalence is increasing quite significantly, and although we have been discussing a lot, I think it still remains poorly understood. A lot of new aspects of that are coming out during the discussions, as we have just seen in the previous session also. And and the name itself is a misnomer, as was being mentioned, that the focus is on the ovarian morphology, but that's not what we are. And even when you look at the ovarian morphology, it's not exactly the way the name stands, but there is more to it. There are a lot of other aspects that need to be discussed. And if you look at the prevalence, the global prevalence probably is about 2.2 to 26%, and in India itself, the prevalence rates have been variable from various different studies, and we have different studies quoting prevalence rates as high as 36% in adolescent girls also. And the androgen, by using different criteria, and the other complexity is that by using different criteria that are available for the diagnosis of PCOS, we may have different prevalence rates. They may vary based on for the same population, based on the criteria that are being used. There are several alternative names being proposed, suggested because of the fact that there are different mechanisms involved, and whether it's the insulin resistance, which is the primary factor, or whether it's the ovarian hyperandrogenism, which is the major event, is the major question which remains unanswered, because we have a lot of new information coming in, and the difficulty is diagnosis is always there because of the clinical heterogeneity, the different criteria that are present, and the focus of these diagnostic criteria has been on different aspects. As the time evolves, you've seen that the Rotterdam criteria had a different focus of for the diagnosis, while the AE excess society, the androgen excess society, focuses on the androgen hyperandrogenism, and the ovarian appearance, which is not pathognomic, insulin resistance, which is an important component but which is not included in the diagnostic criteria, and the fact that we need to exclude many other conditions which are significant mimickers of the problem. But what is clearly understood is that there are three important components. One is the chronic oligoanovulation, the polycystic morphology of the ovaries, which is not essentially present in every woman, and similarly hyperandrogenism, which is present in most but not in every woman with PCOS. And this is just to illustrate that the diagnostic criteria are different over the years, have evolved, have been different. And when you look at the Rotterdam criteria, typically we are looking at 2 out of 3 factor out of these 3 conditions, being present. And when you look at the AXS society criteria, they have focused mainly on the hyperandrogenism and one of the other factors being present. The common exclusion criteria are to be looked at, and we have to keep this in mind when we are diagnosing PCOS. And whenever we look at women with PCOS who have alternative who have significant oligoamenorrhea, some of the other conditions that need to be excluded are the chronic illness, stress, excessive exercise can also cause menstrual disturbances, eating disorders, poor nutrition, thyroid dysfunction is another important thing which needs to be excluded every time. So these are things that need to be kept in mind. And coming to the different phenotypes that have emerged because of the different criteria that are used. When you're looking at the classical phenotype, we have both all the three components being present: the ovarian morphology being there, the hyperandrogenism being there, and the oligo-anovulation being there. So this is the classic PCOS, which has greater cardiometabolic risk. And again, if you look at the phenotype B also, where but for the ovarian morphology, the rest of the manifestations are there. Now, if you look at phenotype C, these are the ones who do not have the menstrual irregularities. They have apparently normal menses, and they have but they have the hyperandrogenism and the ovarian morphology. So they are the ovulatory PCOS. And then we have the non-hyperandrogenic ones, which probably have a milder phenotype. So we have clearly seen that these phenotypes are present in women with PCOS, and they have different needs for their treatment, and also this decides the also their long-term outcomes. So if you look at the interesting fact here is that if you look at ovulatory PCOS, probably it contributes to 17% of the women with PCOS. So the rest of them, almost 80% to 85% of women have menstrual irregularities, about which I was going to discuss. So so that forms the basis of the discussion. What I'm going ahead with is that menstrual irregularities are present in almost 85% of women with PCOS, and there's a small percentage which do not have this, and they are probably categorized as the ovulatory PCOS. And as you can see that there is a significant overlap between these three factors that we are speaking of: the oligo-anovulation, the hyperandrogenism, and the PCO morphology. And the extent of this overlap can be different in different women, and the manifestations may therefore be different in different women. So menstrual irregularities are very frequent, present in 75 to 85% of them. And typically, when you're looking at the typical menstrual pattern in women with PCOS, you're looking at cycles which are more than 35-day length, or 4 to 9 periods per year. And occasional menstrual cycles are maybe more normal, but menses may be very light. And some women may not menstruate at all. And we need to typically keep in mind that these menstrual irregularities start in the early perimenarcheal period, and we need to consider other diagnoses if these have started much later after puberty. And the Rotterdam criteria definitely clearly states that when you need to look at less than 8 menses per year to consider oligo-anovulation and the cycle length when it is more than 35 days. The other important factor is that there could be some women who have subclinical dysovulation with anovulation. That is they have apparently normal cycles, regular cycles, but they are not ovulating. And these women, for these women, we often, we need to measure the progesterone in day 20 and day 24 to establish ovulation. In adolescents, particularly, the concerns have to be that that within the first 1 year after menarche, the cycles, we may not use the same criteria as we have used earlier. So there you would use less than 8 menstruations, or more than 2 cycles having being either less than 22 days or more than 42 days per year. With this definition, the prevalence of oligo-anovulation in that age group will drop to 14%, and this becomes more predictive of PCOS in later life. Now, coming to the mechanisms why this menstrual irregularities happen, the common denominator is there are 3 major mechanisms about which we have been alluding to in the previous session also, that it is whether it is the ovarian hyperandrogenism, which is the primary factor, or whether it is insulin resistance causing hyperinsulinism, which becomes a major factor, or is it associated factors like LH excess or obesity, which also contributes. So these are the 3 mechanisms which I'll discuss how they are causing the menstrual irregularities. So this picture actually is quite a busy picture, which shows the effect of all these three factors. That is, whether you're looking at functional ovarian hyperandrogenism, how it is contributing to the PCOS, and whether it's the insulin resistance or whether it is the excess LH secretion from the pituitary. So these are all interrelated, and to understand the clinical, I mean the pathophysiological mechanisms, I'll just try to illustrate them in the next few slides. So what we see is that functional ovarian hyperandrogenism is present in approximately 90% of women with PCOS. It accounts for most of the essential features of PCOS. The excess androgens also act on the pilosebaceous unit, causing the hirsutism, acne, all the features of hyperandrogenism. The excessive intra-ovarian androgenic milieu causes granulosa cell dysfunction, which manifests as ovulation and often leads to PCO morphology. So what are the mechanisms for this functioning ovarian hyperandrogenism? One is the dysregulation of the theca cell steroidogenesis and also the granulosa cell dysfunction. So these are the two major reasons for the development of this functional ovarian hyperandrogenism. The androgen production in the ovary is normally very tightly regulated because and although androgen in excess is causing the harm, but androgen is also required as a substrate for estrogen formation, and androgen is also required for optimal fertility. So, but however, excess androgens are going to disrupt the ovarian follicle development. At the small antral follicular stage of development, the LH stimulates the ovarian theca cells to form androgens, and the follicle stimulating hormone stimulates the granulosa cells to form estrogen. So this is how the production of androgen and estrogens is finally regulated in the ovary, with the LH working mainly on the theca cells to direct influence the androgen production, while the FSH influences the aromatization of these androgens in the granulosa cells. So normally the theca cell androgen production is coordinated with the granulosa cell estrogen production by local factors, the paracrine or autocrine mechanisms, and not by the endocrine negative feedback, which also has an influence, but it's more of the intra-ovarian paracrine effects which have a more significant effect. Within the ovary, the response of LH is modulated by the balance between downregulation and upregulation processes. So the LH response itself, whatever may be the level of LH, the response to LH is modulated by the receptor sensitivity of the LH itself, and that regulates the androgen production in the theca cells. So downregulation results from desensitization of LH receptor binding sites that occurs in the presence of elevated LH levels, and thereby the androgen levels are maintained. The local androgen levels are normally maintained. But this downregulation is counterbalanced by granulosa cell factors that upregulate the P450 C17 activities. Particularly, these are influenced by insulin-like growth factors and inhibin. So these have again a paracrine effect on regulating the LH sensitivity. In PCOS, what happens is that there's downregulation of theca cell androgen production is flawed here. So this does not happen. What normally should happen does not happen, and PCOS ovaries are hyper responsive to LH stimulation. So therefore, there is greater amount of androgen production in the ovary. And apart from the excess ovarian androgen production in the theca cells, in the granulosa cell also there's excess. The excess intraovarian androgen causes the granulosa cell dysfunction that underlies all this abnormalities that happen in PCOS, that is the anovulation and the PCO morphology being developed. The high androgen levels stimulate an excess number of small follicles to grow. This stimulation of the early follicular growth primarily results from increased granulosa cell proliferation, and this is most likely responsible for the increased AMH levels seen in women with PCOS. The androgens also contribute to the premature luteinization of the follicle. That is, the granulosa cell luteinization occurs in the mid rather than late follicular phase, which seems to be the basis for the follicular maturation arrest, and that hinders the emergence of a dominant follicle and precludes ovulation. The increased proliferation of the luteinized small follicles coupled with the maturation arrest before the large antral stage of follicular development manifests as PCOS morphology on ultrasonography. Now, coming to the role of hyperinsulinism, we've just seen the mechanisms by which the functional ovarian hyperandrogenism causes the problem. Now, coming to the role of insulin itself, hyperinsulinism, which occurs because of insulin resistance, is an aggravating factor almost in one half of cases of PCOS. Not all of them have hyperinsulinism, and this the insulin resistance is very remarkable here because it is a tissue specific resistance. We have tissues like the muscle and muscle which is resistant to the action of insulin, but the ovaries remain sensitive to the action of insulin. And this leads to excessive, this leads to all the problems that we are discussing about. So the signaling pathways in the ovary remain sensitive to many growth factors like protein anabolic and lipogenic actions of insulin. These actions of insulin aggravate the steroidogenic dysregulation and contribute to obesity and acanthosis that are common comorbidities of PCOS. So thus in PCOS, what we're seeing is that the paradox of insulin resistance, and at the same time there is an effect of hyperinsulinism, that is the ovarians remain sensitive to insulin and there's an excess state of insulin signaling in the presence of insulin resistance but to the main glucoregulatory effects of insulin. So the hyperinsulinism promotes the functional ovarian hyperandrogenism. The hyperinsulinemia sensitizes the intrinsically dysregulated ovarian theca cells to secrete excess androgen in response to LH. It does this by reversing the LH-induced homologous desensitization of the LH binding sites, which then upregulates the cytochrome P450 C17 activities. Insulin also upregulates the testosterone formation by type 5 17 beta hydroxysteroid dehydrogenase via a transcription factor KLF15 that stimulates adipogenesis. Insulin excess also synergizes with the androgen excess and FSH to prematurely induce LH receptors on the granulosa cells, leading to their premature luteinization and follicular maturation arrest. So, having looked at these, let us look at the effects of LH excess. So there are others who feel that LH excess is predominantly driving the whole pathophysiology of PCOS. So here the increased LH, often accompanied by decreased FSH, was the first laboratory abnormality identified in classic PCOS and is historically thought to play a role in the pathogenesis by increasing ovarian androgen production. Subsequent research, however, has shown that serum LH is elevated in only approximately one half of patients with documented functional ovarian hyperandrogenism. So therefore, it is in these patients that it is the ovarian abnormality that plays an important role. But there is a significant number of women who have increased LH levels, and their LH probably is the primary driver. The homologous desensitization phenomena limits the ovarian androgen excess in response to excess LH in those who are otherwise having a normal ovarian function. So evidence suggests that increased LH observed in patients with PCOS is primarily caused by androgen interference with progesterone negative feedback. So this is another mechanism. If you think that the functional ovarian hyperandrogenism is the main factor, that can also explain the excess LH, and that is explained by the androgen interference with the progesterone negative feedback on the LH secretion. Coming to the role of obesity, we know that there is heterogeneity in the presence of obesity amongst all women with PCOS. About half of them have obesity, while another 1/3 of those who are non-obese also have increased intra-abdominal fat. So although they may appear not to be obese, but they have a functional obesity, that is, they have increased intra-abdominal fat. The obesity aggravates the clinical severity of functioning ovarian hyperandrogenism by increasing the insulin resistance. So thereby, through the insulin resistance, that is one mechanism by which obesity influences the production of androgens, ovarian androgens. Other mechanism being that the effects of other lipokines, the visceral adipose tissue is very metabolically very active and produces various adipokines like adiponectin, which is a anti-inflammatory molecule, while there are other pro-inflammatory cytokines like TNF alpha, and these are having significant effect on increasing the insulin resistance, and also have direct effects on the ovarian sensitivity to the LH. Obesity also is affected by the altered intestinal microbiome. So that is another mechanism. Obesity alters the intestinal microbiome, and that can in turn lead to, through several different mechanisms, can lead to ovarian dysregulation. There are others who feel that it is probably the altered microbiome, which is the initial event, which can in turn lead to obesity and can lead to all the other manifestations. In PCOS, visceral fat contributes more to insulin resistance than does subcutaneous abdominal fat because of its enhanced lipolytic response to catecholamines. Enhanced visceral fat lipolysis is unique to PCOS and not attributable to androgen excess. The free fatty acids and diacylglycerol released from the visceral fat appear to promote the insulin resistance in the liver and muscle. So, having looked at these pathophysiological mechanisms, mainly the ovarian and hyperandrogenism, functioning ovarian hyperandrogenism, the LH excess versus the effects of obesity and the effects of insulin resistance. Let me just conclude by going through what the International PCOS Network has recommended regarding the oligo-ame. Their consensus clinical recommendation says that when irregular menses are present, a diagnosis of PCOS should be considered and assessed according to the following guidelines. They suggest that irregular menstrual cycles are defined as in the age group of in the first 1 year post-menarchal period. You would look at those who have cycles less than 21 days or more than 45 days, while 3 years post-menarchal you would be looking at cycles less than 21 or less than 35 days or less than 8 cycles per year. And in the immediate 1 year post-menarchal period, any cycle which is more than 90 days is also considered as a consideration for considering for PCOS. And primary amenorrhea by the age of 15 or more than 3 years post-telarchy is also a factor which needs to be evaluated. Their clinical practice pearls are that the ovarian dysfunction can still occur with regular cycles, and an ovulation needs to be confirmed. Serum progesterone levels can be measured. So once again, they speak about the dysfunction and these women who have regular cycles but still have subclinical anovulation. They also speak about the adolescents, the various factors that have to be considered when diagnosing, when evaluating the menstrual irregularities in the adolescent girl. Finally, the management is going to be discussed with by Dr. Ganapathy, and Dr. Rajesh is also going to speak about this. So I'll just end by saying that it has to be highly patient-centered, and the next two talks are going to cover these aspects. Thank you all for the patient hearing.